Donc, voilà. Alors, sans plus tarder, le plan aujourd'hui, ça va être de vous présenter le plan Alzheimer au tout début. Ensuite, il va y avoir le portrait de la population qui vit avec un trouble neurocognitif au sein de notre CIUSSS. C'est vraiment la partie de Dr.Vedel. Il va y avoir la présentation par le site de Dr.Albright et on a prévu un temps d'échange à la fin pour pouvoir discuter de tout ce qui s'est dit. Donc, vraiment, on vous invite là, à bien participer, à utiliser soit le chat ou levez la main, utilisez votre micro, ça va vraiment nous faire super plaisir de discuter avec vous. Donc, à ceux qui viennent le joindre à nous, donc merci beaucoup, puis bienvenue à ce tout premier webinaire pour l'équipe du plan Alzheimer. Donc, le plan Alzheimer, c'est en fait, c'est vraiment le Québec qui a élaboré un plan ministériel sur les troubles neurocognitifs. Donc, c'est vraiment, c'est en 2009, ils ont demandé à un groupe d'experts d'élaborer des recommandations sur comment assurer une meilleure prise en charge de cette clientèle-là. Donc, suite à ces recommandations-là, ça s'est mis à s'implanter comme des projets pilotes dans quelques groupes de médecine de famille. Et c'est pour ça qu'il y a certains GMF qui sont vraiment super avancés, super impliqués, puis il y en a d'autres qui le sont un petit peu moins. Donc, on est un bon exemple d'un GMF qui est vraiment très impliqué, c'est le village santé là, où pratique Dr.Albright qui sont impliqués depuis le début. Par la suite, ce qu'on a fait, c'est qu'on a vraiment voulu étendre ça à tout le territoire et dans le fond, chaque CIUSSS a son équipe plan Alzheimer, donc qui est constituée là, pour notre CIUSSS à nous, de moi et de Justine. Donc, vraiment, nous, le but, c'est vraiment d'amener un support clinique au sein des équipes, au sein des professionnels. C'est vraiment beaucoup de formation, du coaching, du mentorat, vraiment pour outiller les professionnels pour solidifier les connaissances et une meilleure prise en charge de cette clientèle-là. Donc, on est rendu à la phase 3 maintenant du plan Alzheimer. Et vraiment, cette vision-là, c'est d'assurer un repérage le plus tôt possible. Donc, c'est vraiment d'aller chercher ces patients-là le plus tôt possible, d'assurer une collecte des données qui est faite par l'infirmière et la travailleuse sociale, vraiment une bonne collecte des données qui va être utile. Et un bon suivi en GMF. Donc, le but, c'est vraiment de travailler en interdisciplinarité et c'est vraiment le sujet qu'on va aborder aujourd'hui avec la présentation de Dr. Albright et bien évidemment, le soutien aux proches aidants. Donc, voilà, je vais passer la parole à Dr.Vedel. Donc, il va nous présenter le portrait de la population vivant avec un trouble neurocognitif au sein de notre CIUSSS. Donc, je vais juste vous présenter un peu Dr.Vedel avant de lui passer la parole. Dr.Vedel est médecin en santé publique et professeur agréé au département de médecine de famille de l'Université McGill. Elle est également chercheuse à l'Institut Lady Davis de l'hôpital général juif Sir Mortimer B. Davis, en plus d'être la cofondatrice et la directrice scientifique de l'équipe de recherche ROSA. Donc, je vous laisse la parole, Dr. Vedel. Bonjour.
Bonjour, merci de cette introduction. Je suis ravie d'être là avec vous aujourd'hui, même si c'est vous qui êtes les experts. Moi, je viens en tant qu'équipe de recherche pour montrer le portrait qu'on a fait dans tous les CIUSSS et les CIUSSS du Québec pour leur rendre un peu les résultats de ce qui se passe dans leur CIUSSS et leur CIUSSS avec les données administratives disponibles que nous avons. Donc, quand vous voyez à l'écran, on a fait quelque chose qui tient en 2 pages. Une première page qui est plus des données quantitatives et une deuxième page des données qualitatives. Donc, sur cette première page, on voit que le portrait de ce qui se passe dans votre CIUSSS du centre-ouest. Et le premier graphique en haut à droite, c'est l'augmentation de la prévalence des personnes qui ont un trouble neurocognitif majeur, donc une maladie d'Alzheimer ou autre maladie apparentée. Dans la population de 40 ans et plus, on voit que vous avez dans votre CIUSSS une augmentation de 64%. Et à l'ensemble du Québec, l'augmentation est de 200% en général. Donc, on fait face vraiment à une augmentation très importante de cette population-là, et ce qui nécessite d'adapter un peu les services de santé et de soins et sociaux. La question qu'on se posait, c'était quel médecin les personnes avec un trouble neurocognitif majeur voient-elles le plus souvent et à quelle fréquence? Donc ça, c'est le deuxième graphique qu'on voit en dessous à gauche. Donc, vous voyez que en gris, c'est les données de l'ensemble du Québec. On a à peu près 60%, dans 60% des cas dans l'ensemble du Québec, c'est le médecin de famille qui est vu en priorité. Pour votre CIUSSS, c'est la barre bleue. Donc, on est plutôt à 50% des cas des patients qui voient leur médecin de famille comme médecin principal. On voit que les spécialistes de la cognition, que ce soit les gériatres, les neurologues ou les psychiatres, sont parfois vus par des patients aussi. Les autres spécialistes, les cardiologues, les pneumologues, etc., les rhumatologues sont vus aussi dans une certaine proportion, ce qui est normal puisque les personnes avec un trouble neurocognitif majeur ont beaucoup d'autres maladies chroniques. On voit aussi sur le graphique un peu sur la droite que le pourcentage de personnes qui ont eu vu au moins une fois le médecin de famille dans l'année, pour l'ensemble du Québec, on est proche de 80%. Dans votre CIUSSS, c'est 75% qui ont vu leur médecin de famille dans l'année et avec à peu près 4 visites dans l'année auprès du médecin de famille. Donc, le médecin de famille est quand même le médecin référent pour ces personnes qui ont un trouble neurocognitif majeur. C'est celui qui est le plus souvent vu par le plus grand nombre de personnes et qui est vu de façon très régulière avec 4 visites par an. En termes d'utilisation des services hospitaliers pour les personnes avec un trouble neurocognitif majeur, on voit, et ça c'est connu, que les personnes sont des grands utilisateurs des services hospitaliers. On voit que dans l'ensemble du Québec, à peu près 50% des patients avec un trouble neurocognitif majeur vont aller au moins une fois à l'urgence dans l'année. Dans votre CIUSSS, c'est 46%. On sait qu'on peut éviter ce genre de visite à l'urgence avec une bonne continuité des soins auprès du médecin de famille. Donc, c'est pour ça qu'on a montré ces deux indicateurs un petit peu collés côte à côte. On voit aussi que ce sont des grands utilisateurs. Hein. On a 30% des personnes dans l'ensemble du Québec qui ont au moins une hospitalisation dans l'année, avec une durée d'hospitalisation qui est de 20 jours, donc qui passent 20 jours à l'hôpital en moyenne. Et dans votre CIUSSS, c'est 27% de la population qui va avoir une hospitalisation dans l'année avec une durée de séjour qui est un peu plus importante que la moyenne du Québec, 26 jours et demi d'hospitalisation. Un autre indicateur qui est intéressant et auquel vous intéressez probablement, c'est les niveaux de soins alternatifs. Qu'est-ce que ça veut dire ça? C'est une personne qui est hospitalisée mais qui pourrait recevoir son congé, sauf que la structure en amont n'est pas prête à recevoir certaines personnes, donc elle reste à l'hôpital, mais alors qu'elle n'a plus besoin de soins hospitaliers actifs. Donc, en général, c'est parce qu'ils attendent une place en RI ou en CHSLD ou en RPA ou l'organisation du retour à domicile. Donc, dans l'ensemble du Québec, c'est près de 5% des personnes qui ont un niveau de soins alternatifs avec des durées d'hospitalisation de 46 jours en niveau de soins alternatifs. Et dans votre CIUSSS, c'est 4,2% de la population avec des durées d'hospitalisation de 65 jours en moyenne. On peut regarder l'autre version. Voilà. Alors là, grâce à l'équipe de Yves Couturier de l'Université de Sherbrooke, il y a eu aussi un portrait qualitatif de qu'est-ce qui se passe avec le plan Alzheimer au Québec et dans les différents CIUSSS et SUSS. Donc, ils ont relevé dans son équipe quels sont les éléments facilitateurs de l'implantation du plan Alzheimer. Ça doit résonner avec votre vécu. Il y a eu une bonne gestion du changement avec vraiment un souci de faire évoluer les choses. Une bonne augmentation des capacités et des compétences des infirmières en GMF. De plus en plus un travail interprofessionnel en GMF. Le sentiment qu'on repère davantage les patients et qu'on fait davantage de diagnostics en GMF. Une meilleure articulation entre les services de proximité, les GMF, les services de soutien à domicile et les services spécialisés. La mise en place d'équipes SCPD, donc ces symptômes comportementaux et psychologiques de la démence, je pense que vous connaissez tous ça, mais c'est les personnes qui sont qui ont des troubles agressifs ou de déambulation ou de fugue ou des symptômes qui sont parfois plus difficiles à gérer. Un maintien des ressources territoriales et un travail vraiment engagé malgré la pandémie. Bien sûr, il y a eu des défis et tout n'a pas été simple, notamment entre la phase 1 et la phase 2 du plan Alzheimer, le passage du leadership de l'implantation du plan Alzheimer qui était initialement dans les GMF, là qui est passé dans les CIUSSS. Une faible coordination ou continuité entre les GMF et les services de soutien à domicile. Le rôle des travailleurs sociaux en GMF qu'il a fallu calibrer, c'était un petit peu nouveau. L'adhésion de certains médecins pour détecter et diagnostiquer les troubles neurocognitifs demeure un défi dans certains endroits. Et on s'est beaucoup concentré finalement sur détection diagnostic au détriment, je dirais, du suivi des personnes. Qu'est-ce qu'on fait une fois que le diagnostic est fait? Comment on coordonne la trajectoire? Une difficulté de voir quels sont les changements vraiment qui se mettent en place. Bien sûr, la COVID et qui a ralenti notamment tout ce qui est coordination et implantation au niveau du Québec. Alors, il y a eu particulièrement des bons coups qui ont été révélés dans votre CIUSSS. Le fait qu'il y a une volonté, beaucoup d'énergie mise pour rassembler les différentes directions, hein, parce que les patients avec l'Alzheimer, eh ben, ils ont besoin de plein de services, donc il faut mettre plein de monde autour de la table. 2 chefs de programme qui sont dédiés au GMF, qui sont présents sur le terrain et qui continuent à porter la mobilisation du terrain. La mise en place des unités de pratique intégrées, donc une réorganisation de services qui permet de mieux se coordonner. Aussi le développement d'une trajectoire de soins SCPD. Tout ça vise à une meilleure intégration des différentes directions. Aussi la mise en place d'une coordination GMF qui favorise la création de liens entre ces différentes organisations. L'investissement des pharmaciens motivés, volontaires, un spécialiste en activité clinique et en soutien aux travailleurs sociaux et un travail de forcené des ressources territoriales très proactives et se remplaçant, etc. Il y a des défis, c'est certain. Le défi perpétuel de maintenir engagées différentes directions du CIUSSS. Le partage du travail entre l'équipe de psychiatrie et celle de gériatrie, c'est un peu comme si les troubles neurocognitifs majeurs tombaient entre les deux. Et l'équipe qui apporte le soutien pour les SCPD ont beaucoup de demandes et ont du mal à faire face à l'ensemble des demandes qu'elles reçoivent. Ce portrait est peut-être déjà un petit peu daté, ça a peut-être évolué depuis, mais voilà ce qu'on a vu pour votre région et j'ai tenu 10 minutes, je suis contente, je suis dans mes temps.
Non, c'est super, vraiment. Merci beaucoup d'avoir fait ça en 10 minutes parce que ça l'a quand même demandé. Normalement, on passe beaucoup plus de temps pour expliquer ce portrait-là, mais merci beaucoup. C'est vraiment super d'avoir des chiffres et aussi des données, des données comme ça. Pour nous, c'est très motivant de voir ce qu'on a fait comme chemin, mais aussi ce qu'il nous reste à faire c'est vraiment une chance d'avoir un rapport comme celui-là. Je vous remercie beaucoup d'avoir fait partie de la présentation. C'est très, très apprécié de vous avoir parmi nous. Donc,
Avec grand plaisir.
Donc, on va passer à la présentation de Dr. Albright. Donc, comme je le mentionnais, là, la présentation de Dr. Albright va être en anglais. Par contre, on vous invite à poser vos questions en français ou en anglais, il n'y a pas de problème. Donc, avant de laisser la parole à Dr. Albright, je voulais juste le présenter. Donc, il est médecin de famille à Village Santé. Donc, il a fait partie du plan Alzheimer depuis le tout début, là, donc en 2016. Il est également professeur agréé à l'Université McGill au département de médecine familiale. Donc, je vous laisse avec Dr. Albright. So I will stop sharing my screen so you could share yours. And there you go.
Grand merci, Fatima, pour l'introduction. Mais effectivement, mes diapos sont en anglais, mais je peux faire la présentation en français si c'est préféré ou c'est prévu en anglais. Ou c'est comme un
C'est vraiment vous.
on peut aller entre les deux.
Parfait, ça c'est bien.
So I'll jump back and forth in a little bit. The slides are in English, but I can answer your questions in French. So I'll keep my eye on the chat on the side. If I don't get to you right away, I'll get you at the end. You can just maybe chat it again.
On va s'en occuper aussi pour s'assurer les questions dans le chat. On va tenir un contrôle sur ça aussi. Là, donc,
So I have no conflicts of interest to declare. I have no commercial ties to any industry. All of the slides that are showing me the tools are all taken from the Quebec Ministerial Alzheimer Action Plan or from the INESS website. So I thought we'd do a case-based approach for this to show really how a multidisciplinary approach can facilitate the care and the management of patients with neurocognitive disorders. So I'll start with Mrs. S, who I'm sure we've all seen patients like this in our practice before. She's a 71-year-old lady known for diabetes, anxiety, and depression. She lives alone and doesn't have any close family, and she does hold a driver's license, but she doesn't drive or have a vehicle right now. She takes lorazepam, 0.5 milligram every night to sleep, and is on treatment with venlafaxine, 50 milligrams each day. She's not seen a doctor in many years. She's taken on in your practice, and she's complaining about memory loss and also wants to see somebody for her mood. So very typical presentation, and the patient is actually complaining about memory problems. And then another case you might have, 65-year-old gentleman with past medical history of stroke with an ongoing right hemiparesis, hypertension and dyslipidemia, and diabetes. He lives alone. He's an immigrant from Pakistan. His medications include atorvastatin, aspirin, metformin, ramipril, and indapamide. And this patient's not complaining of any memory problems or any functional disability. Oh, do people see the diapo?
Yeah, well, apparently there's an issue. I don't know. Est-ce que c'est le cas de tout le monde? Est-ce que tout le monde voit les diapos? Non, je peux les... OK pour moi. Donc, ça semble être un problème. OK, donc, you can continue and I will manage with the person. It's OK.
Excellent. This patient doesn't have any actual memory complaint to you, but you do notice while caring for Mr. K that he frequently has unexplained absences from clinic visits. So why we might want to do some case finding for Alzheimer's as well. So I'll get to those cases and we'll work through them as we go through our presentation today. So why manage neurocognitive disorders in primary care? Well, as we can see, patients having poor access to specialist care. And even when they do, it's not clear that memory clinics are providing any superior care to what can be done in a family medicine home. Additionally, the family medicine home has better links for community services and can offer a comprehensive place of care for the patient. So there's a lot of advantages to managing neurocognitive disorders in primary care and not a lot of clear reasons why they would need to be referred to a specialist. So there's a strong case to be made. And the model I'm going to propose today, which has already been adopted a lot of the GMFs across our CIUSSS, is to manage them in a interdisciplinary fashion. very similar to how we've been doing for years for our other chronic diseases like COPD, diabetes, hypertension. And we thank the ministry a lot for the different support and the training they've offered our personnel, and so they can help us do this. So to give you a little bit of an overview of the model for care. So the patient will come to their family medicine group, the GMF, and they will be responsible there, the GMF, for case finding, diagnosis, treatment, and follow-up, sharing responsibilities between the family physician, nursing, social work, and then communicating as needed with outside services like specialized memory clinics, maybe the neuropsychiatric, the SCPD volet for behavioral problems, communicating with home care services like this service for elderly patients at the CLSC. And so that's really the model we want to propose. So focused, where the patient is getting their needs met in the family medicine group and referring to additional services as needed. So I want to talk a little bit about case finding. So for case finding, we just want to emphasize that all the societies still recommend no routine screening for neurocognitive disorders. We shouldn't blanket be screening people because of any age threshold, but we should be investigating patients who do potentially have neurocognitive disorders. So, for example, people who come with memory complaints, or in certain situations where they might have predisposing conditions for neurocognitive disorders. So patients with late onset mood problems in life, people who have had new onset anxiety, new onset depression late in life. It's a bit unusual. We should always look for comorbid neurocognitive disorder. Or patients like we had in our second case, Mr. K, patients who've had strokes or other diseases that might affect their memory. So we really want to emphasize, not just addressing patients who are coming in with complaint of memory loss or functional disability, but other patients, case finding, investigating patients who might have be presenting some symptoms, even if they're themselves not aware of their memory limitations or not complaining about their memory limitations. And there's quite a few different useful tools that can be used for that, and they can be accessed on the ministerial website. And one is the Alzheimer's Disease Questionnaire 8. So the Alzheimer's Disease Questionnaire 8 is a very straightforward yes/no questionnaire that can be administered 8 questions. So it takes only about 2-3 minutes to administer the questionnaire. It can be easily accessed through your electronic medical record. And so if you see someone who's going in this case finding, situation, someone who just came out of the hospital with a delirium or with a stroke, or somebody who you're noticing, maybe frequently having a lot of trouble communicating with them or organizing their appointments, this can be one of the screening tools you can use. My personal favorite is the clock draw. And so it's very simple. This doesn't require any checklist or anything, opening any tabs in your electronic medical record. You can just ask the patient to simply draw an analog clock. And usually you can ask for any hour, but usually you ask them for 5 or 10 past for the minutes, because you want to see whether they put the minute hand, if they put it correctly, because usually 5 and 10, a lot of patients trip themselves up and draw it all the way to the 5 or the 10 on the clock and not the 1 or the 2. And if you get something like on my slide here, maybe your patient is a surrealist painter. But so to return to our cases. So both Mrs. S and Mr. K are both cases where we would want to investigate further for memory problems. So in Mrs. S, in our case, it's very obvious. She has presented to you with memory problems. And additionally, even if she didn't, there might be concerned if this was a new or a poorly managed psychiatric problem in the elderly. In Mr. K, he's not actually coming forward to that, but he does have some risk factors. He does have a history of stroke, so that might warrant looking at. And he also was frequently missing a lot of appointments. So final message, don't screen everyone, but aggressively case find if you find any risk factors. Now, the problem with dementia assessments is that they can be quite time consuming. So we found a nice model here, which is the one that's available through the Ministerial Alzheimer Action Plan, in order to break it down over multiple visits with multiple professionals so that it's easier to manage this assessment and that we can ensure you get a complete picture. So the first step for the evaluation is really to do this, case finding or to have the symptoms. And then when there's concern, the physician can refer them to the nurse, who will sort of fill in the rest of the picture around the diagnosis. So looking at the patient's home situation, who are their caregivers, what is their functional status? Are they able to independently administer their medications? What are all their IDLs? What are all their ADLs? Review all their medications and really complete this picture, and also do a cognitive investigation. So decide on an appropriate memory screening tool, whether you use a mini mental or a MoCA, and administer that. Usually I prefer to go with a mini mental first, and if that's good, then we can arrange a follow-up visit, because sometimes it's too much to do all the testing in one visit, and be a little bit patient with that. So I usually prefer to start with the mini mental and get that baseline information. So we're at step 3 now. So we've had our initial case finding or presenting of symptoms. Then we're completing in the patient's home situation, their function, and then we send them back to see their family physician afterwards. So just a quick review. During this first nursing evaluation, there can already be some steps taken to facilitate this patient's management. So bringing on a contact person or a caregiver who will assist the patient through the diagnostic process, looking at social supports, maybe bringing in social work, and making some links with community resources like the home care services at the CLSC. I'll just answer Elodie Belange's questions. Do you want to not start with the MoCA for an educated patient? So if ideally in the perfect world, you would get both cognitive tests, but it's not always possible. And actually, generally, if you're looking at education or not, I would not use that as the basis of which tool to use. The MoCA tool can be useful if your patient is really high functioning and has a high level of education, because sometimes a full STEAM might not be sensitive to pick up on really early changes. But the actual goal of these tools was MoCA was to get the more subtle changes that we'd see in mild cognitive impairment, and the full STEAM to see the more dramatic changes that we'd see in dementia. So if I had to go with only one tool for the first test, I would go with an MMSE. But if you feel like the patient's very high functioning, you want to start with a MoCA, that's fine too. And in our CIUSSS, we have a nice little tool like this that allows us to quickly evaluate the patient at subsequent visits. And it's very easy. You can clearly see, in terms of what's the patient's functional status, what are they having problems with right now, are they able to compensate appropriately, or do they need more help? What's their history of hospitalizations? Were they started on many medications? And I see in the comments that Reine Bonadel says that usually they can do both as together, and that's fantastic. If you have both as a clinician, it's a lot easier to make an assessment. So after this evaluation, now we have a pretty complete picture of the situation. So the physician, picked up on some memory complaints, referred them to the nurse, who was able to get a fuller picture, do some cognitive testing, start some links with community services. And so now the physician can complete the diagnostic evaluation. So one of the key elements of this is to really look at the history. Is there a decline? Is this over time? Is it progressive? And to complete a physical examination, paying particular attention to the neurologic exam. So are there any focal neurologic findings that are suggesting that the patient has a central neurological problem? Is there any signs of Parkinsonism? And then order any necessary blood work and neuroimaging. So I'm going to jump forward and back. Just a kind of quick review for the clinicians here for diagnosing dementia. So most across Quebec, we're mostly using the DSM-5 criteria. So cognitive impairment in at least one domain. It doesn't have to be memory, but usually almost all dementia syndromes, we will see memory involvement. The impairment must represent a decline from a previous level of functioning. So, somebody who never cooked, maybe it's the classic case of old man, his wife always cooked. She passed away at 75. He's not going to learn how to cook. It's not dementia, even if he's completely dependent for all his meals now. Similarly, we see some people never manage their finances. They always had their spouse do it, and then they just delegated it to a child when they were widowed or a widower. That's perfectly fine. It's really, you want to look at a decline from a previous level of functioning. And this impairment must interfere with their independence and everyday activities. You want to make sure the impairment does not occur during the course of delirium, and it's not better accounted for by another mental disorder. So I'll jump back. So we're still at our first visit, and we can now order any appropriate testing, and then we can talk about following up with the patient and with the nurse in order to provide the patient with the diagnosis. A lot of times I get questions, what is the required medical workup when you're examining a patient with dementia? There is no one-size-fits-all answer. It's very dependent, case-to-case basis. The most important thing really to do is to do a neurological examination. And if you have a normal neurologic examination and your history is typical for, like, let's say an Alzheimer's type dementia, you really don't have to do neuroimaging. So CTs or MRIs or something more fancy like FDG PET, those are not necessary for routine investigations. When might you want to do neuroimaging? Well, if the case is not typical, so people with early onset, anybody who has any neurologic findings, you're going to want to investigate. If it doesn't seem like a typical Alzheimer's or mixed dementia presentation, if you're worried that looking more like a frontal presentation with, predominantly behavioral problems. And finally, anybody who has high risk factors for vascular disease. So if there's the patient with known atrial fibrillation, things like that, you would probably want to make sure that they just don't have any silent strokes that are accounting for their memory problems. I see Annie Labrassa has a question, so I'm just going to address that. For patients with cognitive complaints that are referred for a psychiatric evaluation, should any questionnaires be attached by the referring physician? Would it be pertinent for the GASMA nurses to have additional training to help in identifying these patients, as cognitive screening is rarely mentioned in these requests? So yeah, I think if you're going to send your patients to GASMA, for sure, if you did do any cognitive testing, you would want to include at a minimum the results, and ideally, if you can, just send over send over copies of the score sheets for their MOCA and for their MMSC. There is support from the, I'll just jump back a few slides, from the Ministère in Training our health professionals to do other kind of questionnaires too. For example, geriatric depression scale screening. So looking for, is there, is this possibly a mood disorder that's presenting with cognitive impairment? Would it be pertinent for GASMA nurses to have additional training to help in identifying these patients? I think that might be a little bit out of my expertise to answer. Maybe I could let someone who, worked for GASMA do that. I think that most mental health workers, though, are sensitive that cognitive impairment could be a component of any new psychiatric presentations in the elderly. So I'm not involved with the training those personnel, but I think they are. I think that's a well-known phenomenon, and I would be surprised they weren't sensitive to that. I do agree, though. It's interesting. You mentioned cognitive screening is nearly like a prerequisite for these referrals. Sometimes I like to get ahead of the game when I myself am referring, because I do frequently get in the response, rule out cognitive impairment. So I think it is worthwhile to get ahead of the game. And if you have a patient who is elderly with new psychiatric problems, it's definitely worthwhile for you to use something like this model to assess their cognition before sending them to the Guichet Accès Santé Mentale. Going back to the medical workup, so we talked a little bit about neuroimaging, and similarly for blood work, there's very little blood work that's absolutely essential. Actually, if you look at the American Neurologic Association, the only two blood tests they really unequivocally endorse would be a thyroid function test and B12 levels. Although most clinicians would probably also do like a blood count, electrolyte panel. I get a lot of questions about screening for neurosyphilis. It's only necessary if your patient has risk factors. You don't have to blanket assess everybody for syphilis. Sometimes I like to include an extended electrolyte panel as well, calcium, magnesium, phosphate, since those anomalies can precipitate cognitive function, although it's usually more in the context of delirium than a chronic complaint. So really, again, the only absolutely essential blood tests to order are a B12 and TSH level, but I recommend like a general blood panel can be very useful. So we're going to be, we're getting down to the bottom part of this this diagram now. So we've had our patient, we sent them for a medical workup. We did our blood tests. We decided if neuroimaging was necessary. We've clearly established with our diagnostic criteria that this is a diagnosis of dementia. So we bring the patient in, we meet with them, and this is really a good time to have the whole team there. So we've been using separate visits with the nursing staff and separate visits with the medical staff. It's a good idea to have a big visit, get everyone together and have the caregiver present. And one of the important things is to disclose the diagnosis to your patient. It's still a bit of a taboo subject to talk about dementia, but actually it's very important that you offer the opportunity to your patients to understand their diagnosis, and it helps quite a bit in terms of preparatory planning. If your patient is still very high level, still early in the disease, still has a lot of functioning, that they can adequately prepare for what's to come, start getting they can understand that this is they have a serious problem and that this is going to get worse, and that they need to start making plans for what are they going to do for managing their finances, what are they going to do for their testament, who do they want to care for them, where do they want to live, while they still have as much of their capacity as possible. So it's very important to offer that opportunity to the patient to disclose the diagnosis, and then also to discuss options for treatment. Now, we are here now almost 20 years since these medications entered into the market, and lots of failed Alzheimer's drugs. And so the current medication treatments for dementia remain very modest. The analogy I like to use when I explain this to my patients is that this might be the equivalent of kind of tapping on the brakes. It might slow things down a little bit, but it's not going to stop it completely. But the treatments are relatively well tolerated. And so I usually am pretty pro pharmacotherapy, even if the benefits are quite modest. We have 3 different cholinesterase inhibitors on the market. They are donepezil, galantamine, and rivastigmine. And my go-to is donepezil because it's the oldest on the market, but all of them are fine. These medications can be a bit rough on the digestive and the genitourinary tract symptom when starting, a lot of risk for diarrhea, indigestion, and incontinence. And so I usually do a slow increase titration up over a month for these medications. None of them are necessarily better tolerated than the other. So you can start with whichever one you want. If the patient does develop an intolerance to one of the medications, though, it is okay to try switching to another one to see if it's better tolerated. For the surveillance for these medications, the absolute most important thing to monitor is to assure that your patient doesn't have a bradycardia and monitor their pulse both pre and post treatment, because there is a significant risk for bradycardia and syncope with these medications. So that is the most important thing to assess before. If this patient is still coming into clinic, it's totally fine to do a cardiogram. And in fact, I usually prefer to do it for all of my ambulatory patients. But if they're in a situation where it's quite difficult for them to get a cardiogram, let's say it's a home care patient, and they're really preferring comfort care and not doing too many investigations, it's all right. It's perfectly acceptable to just monitor the pulse during your clinic visits and assess for any symptoms of bradycardia or syncope. The medications are relatively easy to get covered by the RAMQ. You just have to still do a patient exception, which has to be repeated 6 months into treatment and then repeated annually thereafter. Usually the mini mental, the MMSE, has to be between 25 and 10 for the RAMQ to accept the treatment or the renewal. But I've had great success when there are mitigating factors to continue treatment. For example, I have a lot of patients who have advanced dementia but have significant behavioral problems that have responded to treatment with these agents, and I've always been able to get the RAMQ to accept, to prolong their treatment when I carefully documented the effect that this medication has had on their behavior, as well as documented the reason for continuing the treatment even in advanced dementia when I make my request to the RAMQ. So it's relatively easy to have these medications renewed. In terms of memantine, a little bit less used these days. It's perfectly fine for patients who cannot tolerate an acetylcholinesterase inhibitor, so that you, if they, you try it, maybe it doesn't work, you switch it over. It doesn't work, you can try it. And it's also has some utility in advanced dementia, but it's kind of like a bit of a Hail Mary. It's not something you really have to go to in all your cases. Besides the pulse, the other really important clinical parameter to monitor is your patient's weight. because it does affect digestion. If you have a very thin patient, so a lot of my elderly women who are quite thin and who are tea and toasters with very small diets, I tend to be very cautious with that. And if I see a lot of weight loss, I either reduce the dose, switch the class, or even just review if the treatment is still really worth it if I see significant weight loss, which I've only seen once, but it was pretty dramatic, and we moved them to memantine. I was asked about pharmacologic surveillance for these agents. The main actual surveillance is your clinical parameters. Does memantine decrease appetite over a period of time? Not usually. It's not as impressive as the cholinesterase inhibitors. Yep. We've used this multidisciplinary model for the assessment, and the multidisciplinary model has a lot of benefits for the follow-up of our patients as well. So the plan is that afterwards we have that visit with all the implicated staff at the patient's family medicine home. And then we've had a discussion about treatment. Maybe the patient was interested in treatment. Then have a follow up, maybe even just by telephone with the nurse, 2 to 4 weeks, to make sure the patient's tolerating the medication, make sure that those side effects that we discussed are not intolerable for the patient, or if they are, to discuss the physician, do they want to change the treatment plan or the dosing. And then that opportunity to continue this shared care management for the patient, because dementia is a progressive disorder. So it's natural to anticipate that these patients will have further care needs. There might have to be increased services involved as time goes forward. And so to continue this shared care model, so there can be efficient communication between the patient and their caregiver and the family medicine home, and between the family medicine home and their community resources. So going back to our first case then, so for Mrs. S, so she was our elderly patient who was complaining about memory problems, and she did want to see a psychologist. So you now seeing this wonderful way to assess your patient. So you arrange a joint evaluation with the nurse clinician. You get a mini mental back. It's 27 on 30, and she's functionally independent. And they also do a short form geriatric depression scale, which comes back 11 on 15. So that's quite high of a score. So moderate to severe depressive symptoms. On their follow-up with their physician, they notice that it's a normal neurologic examination. And do they want to do any further testing at this point? I would say for a presentation like this, neuroimaging wouldn't really be necessary. She's still functionally autonomous. She's got normal MSC. I'd probably, if it wasn't available to do, might do myself a Montreal cognitive assessment, or arrange a follow-up visit with the nursing staff to do that. And I would definitely order some, basic blood work, B12, TSH, things like that. For the diagnosis for this patient, well, assuming we got back a normal MoCA for this functionally autonomous person, I would probably look at her as a pseudodementia case. So I can see that there's a lot of not fully controlled mood symptoms here, which can definitely have a big impact on the patient's cognition. So I would focus on optimizing her depression. Her MoCA, if it came back low, could look at a minor neurocognitive disorder, but really, given that she's autonomous, we wouldn't be too worried about missing a dementia at this time. Important thing when you discuss, mild cognitive impairment or major cognitive impairment, make sure your patients are aware that right now there's no sign of dementia. That's every once in a while, about 10% per year, there's a chance of progression from MCI to dementia. So I always tell them, we're going to keep following you and we'll see how your memory improves, or see how your memory does. So I would optimize her depression management. I'd look at maybe a pretty good dose. She was on venlafaxine 150. So in an elderly patient, I would maybe look at switching her to another antidepressant. I would definitely get her off of her lorazepam with maybe a very slow taper over 6 to 8 weeks, because it's quite difficult to stop benzodiazepines chronically, but those are definitely a medication that can affect cognition. So I would look at, getting the depressive symptoms better controlled. Maybe we could put her on something like mirtazapine, which has a nice sedative effect, so that she could sleep better at night and not need her lorazepam. I would tell her, look, looks like I think your mood problems are probably affecting your memory, but I'm going to follow you and see how your memory does. So in this case, I said, you never know how it could go, but I just say, one way it could go is like, we found out that actually MoCA was a bit low, so she probably does have at least some mild cognitive impairment. We do a home assessment, and then 1 year later, we notice her memory's going down. Her MMSE is now 24, and she's starting to have some functional problems. She's starting to have problems preparing meals on her own. She, finds it's a lot of work. She finds it's a lot of planning. She frequently doesn't have enough food when she goes to cook, and so she's been skipping meals, but she does accept a referral to a Meals on Wheels program. So here we would say clearly we've documented progression of her memory symptoms despite trying to optimize her medication management and improve immune symptoms. So we would actually say now this time she has a diagnosis for a major neurocognitive disorder for dementia. And then we would talk about her and her caregiver and the nurse. We'd meet together again, disclose the diagnosis, and talk about starting some a medication like an acetylcholinesterase inhibitor to treat her dementia. For Mr. K, so he was our 65-year-old stroke patient who was missing a lot of visits from clinic. So him, we do a joint evaluation, and we have right away MMSE is scoring low. And we noticed during this joint evaluation that his function is also not good. He has problem taking medications. He has problem managing his own finances. And that he's very socially isolated. So range links to social work to increase his community engagement. We get home care services involved for a home assessment. And then he has a follow-up visit with his physician, who on the neurologic exam notes a upper extremity and lower extremity weakness, but he says that's been chronic since my stroke, and that's relatively be expected. So what further investigations? So for him, he's definitely the kind of patient where I would like to organize neuroimaging. So I would send him for a CT scan of the head, and I would do the full blood work for him. And for diagnosis, he definitely has some vascular major neurocognitive disorder. The question is whether there a mixed presentation? Is it continuing to be progressive, or is this just all been the same way exactly since his stroke? In the event that it's progressive, I would say it's more of a mixed presentation, and then there's a lot more of a role for treating for a lot more proven benefit for treating for neurocognitive, treating him with a acetylcholinesterase inhibitor for his neurocognitive disorder. If it's been very constant and he's hit this plateau with his stroke years ago and it hasn't changed, he's a lot less likely to benefit from pharmacotherapy in this case. We're getting close to the end of the presentation. I just want to bring up a tool that could be useful for family physicians and for all of our allied health professionals at the patient family medicine home. And that's the SCPD, c'est les symptômes comportementaux psychiatriques de la démence, or neuropsychiatric problems with dementia. And it's a specialized team that can assess patients who are having behavioral disorders. So for people who are wandering, having aggressive behaviors, this is an excellent tool because that's often what is where you might want to start to involve a little bit more specialized care services. So this is an excellent tool, can be referred to in our CIUSSS for assessment. They have psychogeriatrics and specialized nursing staff, and they can really assess both the non-pharmacological and pharmacological management options for these behavioral problems. So I like this tool because this can possibly maintain your patient's autonomy just a little bit longer when these behavior symptoms start to become really problematic, because that's often what really burns out the family and leads to institutionalization. So here are the links. We sent out the files for the different tools. So we have the CIUSSS for their pharmacotherapy and the Ministère for the processus clinique that I was showing for assessment. We have a few minutes left, so I'll entertain if there's any further questions in the chat.
There's one from Elodie. So she's asking, any pharmacological surveillance for these agents? Do we need to have to monitor, to monitor, or I don't know that abbreviation, or kidney fix? So I don't know if you could answer this question. We don't hear you.
No, I had you need a baseline assessment, but you don't have to, unless there's anything that changes your the status of your patient, you don't have to do, there's not really a risk for ongoing monitoring. So you should do probably periodic, because there are dosing adjustments and minimum levels for renal function that you need for these medications. But you don't have to, the periodic, it's not, the medications themselves not very toxic to your kidney or liver. So
there's another question from Orly. So you mentioned you would order neuro management for the patient in your second case. Can you clarify why? And he had been diagnosed with a remote CVS, so presumably he had a neuromanagement in the past.
So for him,
just before you answer your question, I'm sorry, Justine mentioned it in the chat, donc tous vos micros sont activés, donc pour ceux qui veulent poser des questions de vive voix, vous pouvez juste actionner votre micro puis ouvrir vos caméras, il n'y a pas de problème.
So for managing, I didn't talk too much about the neurologic management of his stroke. So his medications look pretty complete for a stroke patient. He's on a statin, aspirin, and hypertension stroke patients, you want an ACE inhibitor and a diuretic. So it looks pretty complete from the stroke standpoint, assuming he got proper assessment for his carotids and ruled out any component of atrial fibrillation. For the memory component, it's not clear for these patients who had a single eventful memory loss after a stroke with no further deterioration, whether there's much of a role for a cholinesterase inhibitor. For patients who have progressive decline, in addition to the stepwise decline, so we say if we look at the patient's cognitive functioning and we say this was time point A and then they had a stroke, all right, and this is their functioning now, but they continue to have a stable over time, no change, it's not clear that they'll likely benefit from treatment with a cholinesterase inhibitor. But patients who have a history of stroke, and then slowly are kind of still slowly headed down over time, have what we call a mixed presentation, and it will definitely help them to treat for an acetylcholinesterase inhibitor.
Fatima, je pense que c'est neuroimaging et pas neuromanaging.
Ah, OK. Excusez, j'ai probablement mal prononcé. C'est un bon exercice de diction. Donc, je suis désolée, c'est moi qui ai mal lu la question, effectivement. Là, je la retrouve plus. Donc, oui, c'est ça, c'est I'm sorry. You mentioned you would order a neuro imaging. Sorry, Dr.Albright. I read.
Yeah. Yeah, I definitely would, because patients who've had strokes in the past have a risk factor for strokes in the future. So I want to make sure that his vascular risk factors are being adequately controlled. So even though we probably attribute his hemiparesis to his past stroke, I would very much anticipate all we probably would find is his old, his old stroke on the scan. But there's a very high possibility too he's continuing to have smaller strokes. So to make sure he's not had some subclinical sort of strokes again that are continuing to contribute to his memory loss. So that's why I would definitely order neuroimaging in the second case.
Thank you. There's another question from Diane Boldick. I'll try this time to pronounce it correctly. What will be the best way to make the client's PG know about those memory difficulties, especially if they are well known at the CLSC SAPA, but without official diagnostic? That's a very good question. I'm pretty sure a lot of people are wondering.
Can you just repeat the first part of that question for me?
Yeah. So what will be the best way to make the client's PG know about those memory difficulties, especially if they are well known at the CLSC SAPA?
Their PG?
Yeah.
The proche aidant, the PG is...
I thought it would be like comme le médecin de famille, j'imagine.
Oh, their GP.
Yeah,
okay. What's the best way to let their GP know? I would communicate directly with his office. So if you're a healthcare worker, I think just a letter directly to the physician's office expressing your concerns is probably the best way. So yeah, I would write you down all the observations you've made and communicate, and then make sure you have your return. So yeah, it's quite easy for me because I happen to practice in a GMF that's inside of a CLSC, so it's pretty easy. But in the outside context, what recommended really is written communication. Because sometimes scheduling a phone call can be tricky going through there. So I would write them a letter documenting all the behaviors you observed and your concerns over the patient's functions, and asking for a follow-up. Yeah.
I hope that answers the question. And we have another one. So medical management for agitation in advanced dementia. So I guess it's a...
Yeah. So bit outside the scope of this talk here, I will bring back to the SCPD. I would use them as a resource if you're having trouble managing agitation. It's, of course, I just want to briefly touch on the fact that really non-pharmacological therapy remains the mainstay for treatment for all behavioral disorders. In terms of medication management, though, if you do need to involve medications, to really look at selective serotonin reuptake inhibitors or acetylcholinesterase inhibitors as first line, and try to avoid use of antipsychotics because of all of the bad side effects and risk of stroke and mortality associated with those. So if you yourself are not usually someone who manages behavioral disorders, I would involve this SCPD team early. And I would definitely involve them before you prescribe any antipsychotics.
Donc, je veux juste amener une petite précision pour l'équipe SCPD. Ils sont encore un petit peu en restructuration. Donc, il se peut que le délai d'attente pour votre réponse soit un peu plus long qu'à la normale. Ceci étant dit, vous pouvez toujours nous consulter, Justine et moi. Vous avez nos adresses courriels là, pour nous communiquer si vous avez des difficultés avec certains patients. Ça va nous faire plaisir là, de vous aider puis de vous offrir du coaching si vraiment c'est nécessaire. Donc, je voulais juste amener cette précision-là pour l'équipe SCPD. Donc, je vois qu'il vraiment, il y a beaucoup de remerciements pour votre présentation, Dr. Albright. Je pense que ça a vraiment répondu à beaucoup de questions. C'était vraiment super intéressant. Pour l'instant, on n'a pas d'autres questions dans le chat. Je ne sais pas s'il y en a qui ont des questions et qui veulent ouvrir leur micro ou vous avez pas mal fait le tour. Donc, vraiment, vous avez beaucoup de remerciements. Là. Les gens sont très satisfaits de votre présentation. On vous remercie vraiment de vous être libérés cet après-midi pour être avec nous. C'est vraiment super. Donc, on va en refaire d'autres, des webinaires qui touchent les troubles neurocognitifs. Là. On voit que le sujet des SCPD reste quand même un sujet qui est important, qui touche beaucoup votre réalité. Donc, on va penser à des sujets comme ça. On va vous envoyer la documentation et un formulaire d'appréciation. Ça va être anonyme juste dans le but de nous améliorer. Donc, je vous remercie à tous pour cet après-midi et je vous souhaite une bonne fin de journée. Merci beaucoup, Dr. Albright. Merci, Dr.Vedel. Ah, je vois que quelqu'un a son téléphone. OK. Si c'était une question. Donc, merci beaucoup, Dr. Vedel. Merci, Dr. Albright. C'était vraiment passionnant de vous écouter tous les deux. Donc, comme vous le voyez à l'écran, les gens vous applaudissent et sont très satisfaits de la rencontre.
Mais grand merci pour l'opportunité.
Merci. Merci beaucoup. Bon après-midi à tous.